I think the good news is these panelists have given us some fabulous handouts. And I now realize that for all my clients who are lawyers, I'm going to tell them to just go back, take about a 6-month course in healthcare policy, and they will be fully employed for the next decade. And my last thought on Pia's presentation is, what's a nice woman like her doing in a place like this? So now we go to the side that has to hire this Price Waterhouse consultant, has to hire the lawyer. We're going to private business. I'm delighted that we have Joe Berardo, Jr., CEO and president of MagnaCare. It's one of the largest regional health service providers in the country. He deals with hundreds of employers, and he is one of the very first in the country to see these emerging trends and how they hit you.
I don't know that I'm the first to see the trends, but I certainly have an opinion on them. And how many of you are benefits people that are in the audience? So that last presentation is job security in my mind. If you can figure all that out, you should be gainfully employed for a long time. So here, my company does deal with self-insured employers from 50 lives, believe it or not. Our largest customer, I think, has 26,000 employees. And it's interesting because there's been a huge shift towards self-insurance. Many large employers are already self-insured, but we're seeing kind of the smaller employers begin to explore it, and there's a lot of interesting products from multiple companies out there that can help. But just in a nutshell, this whole thing, and I've been on record saying this, in fact, on a panel with Kathleen Sebelius, that this whole thing is a disaster from my perspective, at least administratively. What I am encouraged about, and Mike touched on it, is the partnerships that are emerging between providers and payers and employers. And that's kind of the silver lining that I think is going to really help as we go forward. But the regulatory issues and the administrative hurdles that you all have to manage, I think, for the most part, is going to be very, very difficult. I, for one, don't think exchanges are going to get off the ground for October. For those of you that manage sizable employers, you know how hard it is to change one vendor for one plan, on a renewal. So just think about communication, eligibility, data, and then mix in income and all the things, and it's the government. So, and then if you're in this marketplace and you happen to be national, you're dealing with stuff, all over the country, and whether or not they're state exchanges or federal exchanges and your part-time employees. So I've been in Washington quite a bit, just trying to listen and read everything that I possibly can. And I'm really not encouraged that this is going to get off the ground. Are they going to get there? They have to, because politically they have to. But from an administrative perspective, I can't possibly imagine. In fact, one of the administration's people last week said, they've actually lowered the standard from a world-class experience to hope it's not a third world experience. And that's really what's going on. So let's talk about some of the good news. I think what I'm seeing in the marketplace is really the collaboration of providers and payers. There's a line being blurred around how care delivery is going to be delivered in the future. And it's interesting to me because I started in healthcare in 1989, actually working for an HMO called US Healthcare, who was later bought by Aetna, and then I spent the part of the 90s into 2000 with Blue Cross. And I've watched kind of the whole narrow network, capitated program kind of merge into this broad PPO network. Don't want to tell anybody where to go. And part of that was driven by the economy. We had a boom in the 90s that really, for the most part, squashed any kind of control on healthcare. So it's interesting for me now to be in the economic times that we are and faced with health reform. So what we're seeing in the marketplace is, for the most part, we're going to see an alternative care delivery system emerge. You're seeing hospitals, and I have just a one-pager, I'm going to touch on these. You're seeing hospitals and doctors kind of jockey for position. Has everybody heard the term ACO in the marketplace, Accountable Care Organization? You've probably seen a million press releases on it. Generally speaking, there's really not many ACOs that are truly operational right now. There's a lot of press releases. But really what's going on is there is a lot of collaboration. There's acquisition going on by hospitals buying provider groups. There's multi-specialty providers that are expanding geographically, all in an effort to begin to grab market share and deliver product over time. But the good news in the middle of that is there's a lot of information that's going to be exchanged and shared. Because if we're really going to do anything in the marketplace, it's going to come down to the most part of bending the cost curve by doing population management, sharing information, getting rid of duplicative tests and all the things that we kind of know exist today. So for examples, in this marketplace, you have North Shore LIJ that's going to introduce, they already introduced a small group product with Oxford. We're actually going to introduce a large group product with them in the 50-plus market. You have Crystal Run up in the Hudson Valley that are filing their own insurance licenses. You have Mount Kisco Medical Group looking to do the same thing. You have Meridian Health System in New Jersey that's doing a MedCare program and now filing their licenses to do commercial products. So what's going to be interesting for all of you, especially those that have giant geographies to deal with related to your employees, is healthcare has kind of always been local. It got national for a while because the big guys bought up all the regional guys. It's local again, and it's always been local from the delivery perspective, because if you think about it, and we all personally have been in this position, if your employer changed from one carrier to the next, the first thing you do is you go online or you open the book to see if your doctor's in the network and your hospital's in the network. So if you really think about it, that's always been the product. The product is the person that's delivering the care to you and your family. The future, I believe, is going to be a large number of integrated multi-specialty kind of micro networks that are going to have to be delivered across your populations, which I believe the bigger carriers, and we're a smaller carrier here in New York and New Jersey, but I do think that nationally you're going to see companies like ours really be the quilter of these types of programs that will enable you to pick a carrier, but then have these type of local relationships, handle your employees' care. So what does that mean? There's a lot of infrastructure and a lot of population management stuff. Did anybody catch the news on CVS being a villain because they asked personal questions about their employees? Is that ridiculous? And it's amazing to me that the news actually covers stuff like that and makes it a bad thing. So what we're talking about here is we have years and years of data. We have claims, pharmacy, lab values. We've stratified every member of our population. We understand who has comorbidities. We understand who has gaps in care. We understand who's been in the emergency room more than one time in a given year, has had multiple hospital stays. But for many years, that data has not been used and has not been used effectively. So what you're going to see is an emergence of that type of data with health risk assessments. There's glucose monitors out there now that are connected to the cellular network that you get real-time glucose readings that could be reported to care management nurses, so you can manage people real time. And so there's these really great technologies and providers coming together. Now, so how do you get there? You got to manage this stuff first. What are you going to cover? How are you going to cover them? What do the plans look like from a regulatory perspective? But once you settle in on that, I believe the bend the trend and the strategy needs to be really almost a local strategy in each one of the markets that you're responsible for. And also, I think you're going to be faced with seeing providers be part of your product. If you have a large population in a particular geography that's dominated by a provider system, you may look to them for that group of employees to be the organization that delivers your care. And I can tell you, I sit on the health plan associations both in New York and New Jersey, the big carriers are petrified of the providers getting in the business, so directly from a retail perspective. But that's happening, and if you think about even exchanges, and once they finally do find their footing, the only way that affordable products are going to be delivered, at least my opinion, is through real narrow networks that'll deal with the geographic population. I can tell you right now that most of the big carriers, for the most part, aren't playing in many markets on the exchanges. You have big guys that are hedging their bets, saying, we're going to play in exchanges, but they're doing it in select markets. They're going to pick certain counties and certain states and certain things where they can deliver products effectively. In New York and New Jersey, I can tell you I'm not seeing a single affordable product that's going to be available on the exchange. And so now if you couple, you guys, I think, are mostly big employers. If you have the under 50 market and that are dealing with all the things that Pia just talked about, I'm a believer that we're going to have employer dumping. They're going to say, go to the exchange. The exchange, for the most part, may not be ready. But even if they're ready, the subsidies that are available to the individuals, under the 400% of poverty level, even in under 200 where it's substantial, those folks don't have disposable income. So their ability to actually proactively pay or pay in addition to the premium is going to be very, very difficult. And I'm a believer that we're going to have a short-term spike in the uninsureds, and until it finds some settling. Because if you think about it, if you don't get coverage, you're going to pay a $95 penalty, and then you're going to be able to go get insurance without a pre-existing condition clause. So there's all these incentives that really haven't been set up correctly, and it's almost like raising kids. You're going to have to go let everybody go make their mistake first, and then realize and say, "I told you so." But I do think that it's a very, very complex problem. But I would say keep your eye on the administrative and legal piece. That's so important, as Pia mentioned. And but then beyond that, I think the year 2, year 3 strategy is it's not going to be a one-size-fits-all. It's going to really be you drilling down into your local geographies of where you have concentrations of employees and finding the best partners to deliver your product. And quite frankly, narrow networks, in fact, might be a big part of that. And I say narrow networks because nobody likes to hear HMO. Nobody likes to hear capitation, all these bad words from the past. But I got to tell you, what's old is new again. There'll be different structures. I think they're going to be more provider-based this time versus payer-based, so the providers will organize, which I think could be a very good thing because there's going to be a lot of focus on access. Look for bigger roles for nurse practitioners, physician assistants. There's going to be a huge need for that as people come into the system, and they're going to deliver a lot of primary care. And I would tell you, spend time, if you have employees that stay with your organization, focus on population management. I mean, that will be the key to bending the curve. Am I doing okay? Okay, good. All right, so now let's talk about the data. There's a lot of requirements related to the HIPAA privacy and all the things that go on to delivering a health plan. And in fact, that was part of the news yesterday with CVS, and does the employer have the right to gather this type of information? As the financiers of healthcare, I think it's imperative that you look at the data that you have available to you through third parties. You don't need to have names and lists of your employees related to who's got what. But there's incredible information that really does allow you to get much more proactive in the marketplace. Now, proactive doesn't mean sending a postcard to a diabetic saying, "Hey, you have diabetes, can we help you?" That doesn't work. I can tell you it doesn't work. Models that basically assign a caregiver to those in crisis, to those with chronic disease, are what's going to be delivered. And I can tell you there's great organizations like VNS, ILS, there's all these organizations that we deal with that are gearing up to make sure that care can be delivered in the home. So as an example, you might have a diabetic who's got hypertension who's been in the emergency room 3 times last year, and they're non-compliant with medicine, and there's a bunch of things going on socially. You're never going to find that out through a health coach calling somebody or sending a postcard. There literally needs to be somebody that visits that person in the home. And that's what's emerging on the provider side of this, which is very encouraging. So as you look at your population management programs, don't be enamored by flashy brochures and postcards and we're going to text your member. That's all part of it, but the reality is people have relationships with their providers, and they need to find a trusted advisor that's going to help them through their chronic illness. And let me tell you, if you spend a little bit more money covering things like a nurse practitioner visiting the home and things like that within your plan design, and you save one ED visit, one emergency room department visit, you will more than pay for that on an annual basis just by virtue of having that person stay out of the hospital. And statistically, 29% of people that visit the emergency room are admitted unnecessarily. So, there's a huge, huge incentive to have the right care delivered at the right time in the right setting. So it's really very important that your plans cover the things that historically might not have been something that was covered. And then also things like copays. If you find efficient providers, and I think we have to be careful with now the Cadillac tax, but removing incentives. I can say that I've seen that removing incentives for people to go to providers, removing barriers, so no copay to go to this provider is very, very meaningful. The carrot and the stick stuff is still out there, but I'll leave it on one last thing. It's last week, I think Sears, and I forget the other employer, were in a, you remember who? Darden, restaurant owner. They did kind of the private exchange thing, and everybody chose the low payroll deduction plan, right? So now that's a wonderful thing. I'm sure the employer's looking at it saying terrific. But on the other side of that, when 30% of the people end up with a deductible that they didn't expect or they didn't think about, they just looked at the payroll deduction, that's going to be an issue. So I do think that while we have to manage things as employers, there is a whole human side of this thing that we have to make sure that we find the right balance, in the middle of it. I am a big fan of consumerism. People should know what things cost. But at the same time, I think we have to be careful about driving people into things that are just inexpensive out of the gate from a payroll perspective, but leave them exposed at the end. So I was a little all over the place. I apologize for that, but it's hard to stuff this in 15 minutes, but thank you for your time. I appreciate it.